So I'm going to go ahead and invite Dr. Swati Patel to come back up and finish out this session. She's going to talk a little bit about patient-centered research in Lynch syndrome.
Thank you, Lisa. What an amazing way to start the morning. Incredible presentation by Dr. Stoffel and Sarah Hunt. I'm going to spend a little bit of time telling you about some of the research that we do. And the reality is, this research is grounded in you, right? The questions and the perplexions that you bring to us and the kind of issues that your families contend with. And we started to talk about some of these unanswered questions already. Understanding risk. Why is it that there's some families that have Lynch syndrome, and yet there's few and far between colon cancers, or they're happening at older ages? Do those patients truly need to get colonoscopy at such a young age and with such frequency? We don't know. And then there's the families where, despite doing everything, regular colonoscopies, cancers are happening. Why did that cancer happen despite just having a colonoscopy 6, 9, 10 months ago? The folks that come to us and say, I'm doing everything, I'm getting my procedures, I'm taking aspirin, I'm eating bananas, do I really have a 40% chance of getting cancer? That's what the prospective Lynch syndrome database is telling me. And then a question that Dawn posed last night that at midnight I added to this slide that we don't have the answer to. What about all the things that we're exposed to? How does that modulate risk? Maybe it's actually treatment for a cancer, like radiation treatment. Does that actually increase risk of cancer down the line? We don't have the answers to a lot of these questions, but I'll talk about some of the work that we're doing to seek those answers. And then, of course, some of these questions that Dr. Stoffel raised. How can we change our diet to prevent cancer? Are there non-invasive ways that we can screen for cancer to reduce this burden of frequent invasive testing? And then even when we have it all figured out and have a program of care, how is it that we can actually support our patients and our families to keep track of all this? It's incredibly overwhelming. This is a huge laundry list, and you've seen different versions of this in the prior presentations. There's multiple cancers where we see an increased risk in Lynch syndrome compared to the general population. And thankfully, as we'll learn about throughout the course of today, there are things that we can do to reduce or mitigate that risk. But as we've also learned, it's not as simple as this. Sarah explained how different the risks are depending on the genetic mutation that you have. And this is dizzying, right? Depending on the mutation, there might be testing that you start at different ages, do at different frequencies, surgeries that you may or may not consider at different ages. There is no one size fits all in Lynch syndrome. And to compound matters, our societies, the National Comprehensive Cancer Network, meet every year, and the guidelines are changed and updated based on the newest data, the newest science every year. As amazing as that is, to be reactive to the new science and deliver the most up-to-date recommendations for our patients, how can our patients possibly keep track of all this? Well, if they happen to be privileged to see somebody like Dr. Stoffel at the University of Michigan or our incredible team here at the University of Colorado, we have our finger on the pulse of all these changes. And Lisa Naxel, one of our genetic counselors, sits on the guideline committee and shares all of these things with us, and we discuss them. But what about everybody else? You know, not everybody has access to this type of care. And as Dr. Stoffel explained, we really have only been taking care of the tip of the iceberg. If we think about the adult population in the United States, there's over 1 million people with Lynch syndrome out there that need our services, need our expertise, need our care. So how can we leverage technology? We've heard about kind of approaching technology from the perspective of analyzing data, but what about in just implementing change and empowering our patients to have this information regardless of whether they have access to specialized medical centers? Well, this was kind of the issue that our research team tried to tackle, and you'll see some of these folks in the audience today. I encourage you to ask them more about this, but we wanted to understand from our patients the barriers they face, their unmet needs, and then map out how technology can meet those needs. So we conducted interviews. We sought individuals with Lynch syndrome. Some who volunteered to participate in the study are here today. Others across the country that we recruited and conducted in-depth, detailed interviews. And what we learned that I think will resonate with many in the group is that there's 4 major categories of issues that we learned from our patients that they struggle with. The first is there's information gaps. To getting accurate information, up-to-date information. Oftentimes the guidance that maybe they received was years ago when they were diagnosed, and there's no to stay up to date on what's changing. Providers, my friends, my colleagues whom I practice with, unaware of really the latest recommendations. And then when you seek information online, there's just a real challenge in knowing what sources to trust. We also learned that our patients contend with unrelenting burden. It is incredibly complicated to manage that laundry list of tasks, oftentimes in a system that's disjointed, with some practitioners in one system, other practitioners in another, 7 different portals that you have to log into to see your results. It's extremely time-consuming and psychologically burdensome. And we learned from our patients just the wide range of solutions you all use, ranging from sticky notes on the refrigerator to complex color-coded Excel spreadsheets on your desktops and computers. We also appreciated from interviewing our patients this theme of isolation, that individuals with Lynch syndrome, particularly as they're going through milestones or events with Lynch syndrome, whether it's preparing for screening procedures or new diagnoses, talking to family, dealing with cancer diagnoses, seek connection with people who understand what they're going through. And sometimes seeking that in the existing resources just gets intense and stressful and can be anxiety provoking. And then finally, really a solution that we should have had years ago with the tech that we have available to us, but this challenge in actually sharing the information that you have with the people you want to share it with, whether it's medical test results or genetic test results with your family members, or pushing information to the providers or medical professionals that you see. It's extremely complicated to organize all this information and share it with the people who you want to. So all of these barriers that we learned about, I think, really motivated us to understand how we could map that out into a digital mobile health solution that patients could use to empower themselves and educate their family members, their providers, and know what they need to do. And so what we learned is that that information gap, if really addressed, could provide easy to access, easy to understand, up-to-date information that's reliable and potentially even tailored based on the genotype that you have. Sure enough, you could take these complicated algorithm and lists of recommendations and push them to a device. And what we learned from our patients is that trying to search for these things online is really challenging, and they would just prefer tailored information to be pushed to them and all of it be in one central place rather than having to save or bookmark a bunch of different websites that have this information. A digital tool could also potentially serve as a place to store information, a centralized location for not just medical records, but reminders, appointments, push notifications, track other health behaviors or diet, a place to store notes or questions for the next time you see your doctor. And of course, we already use our smart devices for a lot of these things, right? Our calendar applications, our to-do lists that are already oftentimes a functionality on our phone. So why can't we just tailor that and customize that for all this Lynch syndrome care? And then, of course, a digital tool has the potential, if moderated, to really be a useful and meaningful social platform where individuals can connect with others that are going through similar situations, share their experiences, share advice in a moderated fashion. And then, of course, information sharing. Wouldn't it be amazing to just store all of your information with a touch of a button, be able to share it with the individuals in your family that you want to share it with, or your doctors. So what we learned from this kind of this study of interviewing our patients, we also interviewed medical providers, is that a digital mobile tool can really simplify management potentially, can centralize a lot of information that's currently in a lot of different systems, and promote community. There's always work to be done with this information that we've learned. We're starting to now think about how to actually build this. You might say, okay, well, where can I download this app that you're talking about? We're working on it. We have seed funding to develop a prototype, and we need your help. We need those among you who have an interest in this, who have a background perhaps in app development, to come participate in building this with us. And then I think always thinking about sustainability. We have, of course, initial support and funding to build a prototype, but we really want to make sure that this is a sustained resource that has enough support to be high quality over years. And so for those of you in the audience that have any interest, go visit our research table, chat with Kat Martin, our research manager, or the research coordinators to understand how you could potentially get involved. So what about some of these other questions around risk? These, are really ever present in our minds because we know that this is an oversimplification of risk. Somebody asked earlier, what does that y-axis even mean? And so as we present these, we know that the risk depends on the genotype, and the data that we have suggests that those with MLH1, MSH2, Lynch syndrome, have a 50 to 60% chance over their life of getting colon cancer, and they tend to be diagnosed with that cancer at an earlier age than individuals with MSH6 and PMS2. So what does that mean? Well, if you think about your family, that means that of the folks who have Lynch syndrome, 1 out of every 2 to 3 people have colon cancer. If they have MLH1, MSH2, or MSH6, and then maybe 1 out of 5 for PMS2, that might sound way too low for some families, and it might sound way too high. So I'll take you back to a poll here. I'd like to just maybe get a sense from you. If you think about your family, your close relatives, parents, siblings, children, how many folks are there that have 3 or more close relatives who've been diagnosed with colon cancer? How many folks with 1 to 2 relatives, close relatives? And then how many folks who have no close relatives? And as we populate answers here, we see Joe scrolling down, and you can see, look at that distribution. Look around you. 1/3 of the people here have no close relatives with colorectal cancer. So we have families like this that Sarah showed us, where there's lots of colon cancer, endometrial cancer, some of these other cancers that we'll hear about today, and it's no surprise, MLH1 Lynch syndrome. Then we have families that come to us because they have a history of breast cancer. There's no colon cancers in the family, and lo and behold, we diagnose Lynch syndrome. And then what's even more disruptive, and this gets to this question of why don't we just do genetic testing in everybody? Well, we might be going there. And in fact, we have families where there's no cancer, not just colon cancer, but no cancer. And whether it was somebody who was proactive and went online and wanted to understand their risk and got genetic testing, or participated in our personalized medicine biobank study, and then got a phone call from one of our genetic counselors over the last year that said, gosh, you have Lynch syndrome. And not just that PMS2 kind that we think is a milder form, but MLH1 or MSH2 Lynch syndrome. So how can we make sense of this? How does this statistic apply to these families and these patients that we're seeing? Because really, there's a huge variability in risk. Dr. Stoffel presented some of the early data that helped inform our understanding of these statistics that we quote you when you come to our clinics. This was an amazing study that was a huge international effort, over 5,000 families, 15 countries around the world, including many centers in the United States, University of Michigan, University of Colorado. And this is one of the most recent high-quality studies that produced some of these statistics of what the lifetime risk of colon cancer is. It's important to note that this is what we call a retrospective study, meaning The data was collected in 2018, and we looked back at which families got cancer, which members got cancer, and inputted all that data. It's very evident to us that there's a spectrum of risk. We've got these families that appear to be low risk, no cancer in the family, no colon cancer in the family or other cancers. And then certainly our traditional kind of historical Lynch syndrome families where there's a lot of cancer. And so probably there's a spectrum of risk. We think about bell curve distributions. And the data that we have, what we've been quoting you, is probably only reflective of the highest risk individuals, right? Because 2018 and looking back, our approach to genetic testing and how broadly we offer genetic testing is continually evolving such that we're quoting individuals who are diagnosed in the contemporary era statistics for probably the highest risk among us. The reality is it's actually kind of a U-shaped curve. And there's really elegant data from the Mismatch Repair Consortium that showed exactly this, that even in these high-risk genotypes, MLH1, MSH2, there's a U-shape to this. There are some families, of course, that have very high risk of getting cancer, upwards of 80% plus. But then there's a peak on the low end of risk. So there's something that either turns risk on or keeps it off. The risk curve is probably more of an L-shaped curve in MSH6 and PMS2, where there's a huge proportion of families that appear to be at somewhat low risk, but not all PMS2 families, not all MSH6 families are immune. You can see that although much smaller, there are families that are on the high end of risk. So the key question is, what is it that makes families or individuals high risk, and what is it that perhaps protects certain individuals with these genetic mutations? Well, we've alluded to this throughout the day, but it's probably a lot of factors. We see some of these things track through families, and so there's likely other shared genetic factors, as Sarah mentioned, potentially other familial shared exposures, our medical issues, the medications we take that can modulate risk, how we live our lives, our exercise habits, our diet, our habits. And then, of course, what we're exposed to, our stressors, whether they're environmental stressors or the stressors that we live from within. And then all these things that we've been advising our patients to do that we think decrease risk, but to what degree do these colonoscopies, upper endoscopies, urinary tract surveillance, aspirin modulate risk? And are some people better suited to these risk reduction technologies than others? And so why can't we just answer these questions? Why can't we just, look at the patients that we have, and maybe Dr. Stoffel and I just combine the 800 plus patients that we take care of and start whittling away at these questions? Well, we have a few problems. One is that you need big numbers to answer big questions. And yes, machine learning can help us make sense of that data, but you need enough answers. You need enough people to compare to understand whether a risk factor actually changes outcomes of cancer. We need to speak the same language. University of Michigan has a rich registry. They've been collecting data for decades. We have a registry. Cleveland Clinic has a registry, but everyone's collecting data in just slightly different ways. The exact same patient can answer a question about radiation treatment in 6 different ways. If we're not speaking the same language and harmonizing data, it's really of no use or ability, right? So when you talk about machine learning, it has to be clean, kind of tailored data. And we need to keep up with the times. So much has changed. We've seen the evolution of Lynch syndrome a few different times this morning, from when the genetic underpinnings were kind of determined in the 1990s. But from the perspective of how we find patients, gosh, we now really are expanding our genetic testing availability such that with the emergence of these multi-gene panels that many of you have had, we're testing more and more people. Our guidelines are changing in real time. The way we care for patients, our colonoscopy technology has leaps and bounds improved, just like your cell phone. And the resolution from that original iPhone to now the latest version, we can see so many more things with colonoscopy. And as of 2025, use artificial intelligence, AI, little bounding boxes that help us when we're scoping find polyps. And then, of course, when we find polyps, we have really sophisticated ways to remove these, even if they're early cancers. We have other risk reduction things that we've heard about, aspirin, resistant starch in bananas. So how can we truly answer these questions in a rapidly evolving landscape if we're always looking backwards? We could pool all of those international sites again, but by the time we publish the study, it will be outdated data. So we need a way to keep up with the changes in the field, whether that be new ways of understanding risk, whether that be vaccines, whether that be new medicines to decrease risk. And that really is the underpinnings for why we have launched this lineage study that Dr. Stoffel referred to. We need these big numbers to answer these really important questions, and we need to speak the same language. And so we're really excited to have over 40 centers across North America. And I will indicate and clearly state that really it's North America. We have Canadian sites that are on board and interested. And in fact, as we've built this consortium, we have interest internationally, but we want to kind of get our groundswell of data going in North America. But our vision is to work together collaboratively. And what we want to do really is develop research questions that are of critical importance to you in your lives, collect standardized data, and support funding acquisition for our patients to really understand, what we need to do to answer these really important questions. And to do all of this in a way that is embodied of our values, right? We are inclusive, adaptive, equitable, high quality, transparent, and motivated, as are all of you, right? You're sitting here on a Saturday morning. So to do this, we really have launched this consortium where we'll not just be looking back and abstracting data from participants who consent from their medical records in terms of their medications, their kind of medical issues, their colonoscopy data, their outcomes of polyps and cancer. But we'll also be conducting patient-facing surveys to understand your diet, your lifestyle, your habits, data about the doctors who take care of you and the quality of procedures that they're delivering to our patients. And then, of course, if you're cared for at one of these lineage sites, potentially also pairing that with biosamples so we can start to think about the biologic questions and are there signatures of risk that we can understand in tissue or blood. And to do all of this and keep up with the times, the plan is to really not just look at all the data we have to date and harmonize it, but annually update it with our patients. You unfortunately are stuck with us to get your colonoscopies every year or two anyways. And so we'll also invite you to give us updates on how things are going if you decide to participate. There are so many questions. We could spend the entire day talking about the work and the research that we're trying to do to answer some of these questions. Dr. Stoffel reviewed some of them. The Lineage Consortium, our mHealth study, is tackling a few of them. Of course, her work tackling non-invasive ways to survey cancer, whether it's with fecal immunochemical testing or our industry partners who are leading a study with Mayo Clinic and Dana-Farber to look at stool DNA markers. We're trying to launch a study to look at dietary rice bran and whole beans to reduce cancer risk in Lynch syndrome. We know it works in the general population. So as you think about some of these things, if they excite you, if they interest you, please visit our research team who's out. You can talk with them during the breaks and let us know if you're interested in helping out. I won't lie, it's a hard time to do research these days, but I think with a lot of the challenges we face, I can speak for myself and I can speak certainly for our team and Dr. Stoffel. We double down. We make our voices heard and we partner with our patient advocacy groups and our industry partners to really emphasize the critical importance that research has. And I'm confident that with the innovative ideas that we have together, collaborating and with our advocacy, that we will move the needle forward. And I completely agree with Dr. Stoffel that it's going to be an accelerated pace of discovery because of the tools that we have at our disposal. And so, of course, there's so many people to acknowledge, but I do want to shout out again all of the incredibly important patient advocacy organizations that support this work and get the word out. Our huge team, many of whom are here. And maybe you'll learn today, if you stick around for the happy hour, that in addition to being GI cancer nerds, we also like to have fun. So thank you so much for your attention.
All right, thank you, Dr. Patel.